طيب السلام عليكم ورحمة الله وبركاته. Today inshallah we are going to have a cardiovascular case. Okay, so let me introduce myself to the patient. Assalamu alaikum wa rahmatullah. Mr. Shuruf. Am I speaking to Mr. Shuruf?
Yes.
How are you, Mr. Shuruf?
I'm fine.
I'm Dr. Mursi. I'm the treating doctor for today. Okay, nice to meet you.
Thank you.
Okay, Mr. Shuruf, I would like to examine your heart. Is that okay with you?
Okay.
Okay. While I'm examining you, if you feel any pain, please let me know so I need to stop.
Yeah.
You have pain in here?
Yes.
Okay, make sure I'm not going to touch this side, okay?
Okay.
Thank you very much. Okay, it's very important to take the permission from the patient and to ask the patient if he has got any pain. He told me that he has got a pain in his left hand, so I will try my best not to touch this hand as much as I can. Okay, cardiovascular examination usually starts with general observation. You need to see if the patient is connected to any oxygen cylinder, if the patient is connected to any kind of, for example, oxygen devices. However, what I can see in here, that the patient has got a right forearm cannula and it looks okay with no features of erythema around it. In addition to that, you can see that there are huge areas of bruising, ecchymosis. In addition to that, the patient has got mid-sternotomy scar with few scars beneath it. In addition to that, I can see that the patient's lower limb has got some brownish atrophic lesions in here. Okay, then the next step is to start the cardiovascular examination by checking the patient's hands. Mr. Shuruf, will you please show me your hands? Okay. Checking the patient's hands, you need to check for any palmar erythema, any Janeway lesions in the thenar and hypothenar eminences, and usually they are painless lesions. In addition to that, you need to make sure that you are not missing any Osler's nodes at the tip of the fingers, and be careful not to touch them because they are painful lesions. So, by just observing the patient's palms, I couldn't detect any abnormalities. The patient told me that he has got a pain in here, so I will try to avoid. I will just have a quick look. There is nothing here in this patient. Okay, show me your finger like this. I would like to see if there is any evidence of clubbing or any splinter hemorrhages. I cannot see anything. Show me in here, please. I cannot see any clubbing or splinter hemorrhages. Okay, now relax your hand. I need to check the pulse. Checking the pulse in the cardiovascular system is so essential. And make sure you need to spend at least 30 seconds to ensure that irregular pulses are not going to be missed. So, checking the pulse, there are 5 important points. You need to fulfill all of them. Number 1, the pulse rate. Number 2, the pulse rhythm. Number 3, synchronization. Number 4, the volume. And finally, the character of the pulse. Okay, so Mr. Shuruf, just relax your hand. I'm going to check the pulse right now, spending minimum of 30 seconds. Okay, the pulse rate is almost around 84 beats per minute. It was a regular pulse, acceptable volume. I couldn't detect any character, and I'm trying to avoid touching the patient. Mr. Shuruf, do you have any pain in here?
Yes, yes.
Okay, I'm going to avoid this. However, I don't think there is radial delay. Okay, now, Mr. Shuruf, do you have any pain in this side?
No.
You don't have any pain? Okay. Keep your hand still. I'm going to lift it up. I need to check for collapsing pulse. No, keep it. I will lift it up. Okay. There is no collapsing pulse. Okay, thank you very much. Then you need to go and start your examination from the patient's eyes going down. Mr. Shuruf, okay, show me your eyes, please. Look up, please. Okay, now can you look down? Look down, look here to my eye, to my hand. Okay,
Yes.
very good. I cannot see any pallor and I cannot see any jaundice. Now, pick up the torch and ask the patient to open the mouth to check for any high arch palate, any central cyanosis, and any gingival hyperplasia, in particularly with these kind of patients who has got midline sternotomy scar. So, picking up the torch, Mr. Shuruf, could you please open your mouth? Stick your tongue to the roof, okay, like this, okay. No central cyanosis. There is no high arch palate, okay. Can you show me your gum like this? There is no gingival hyperplasia. Thank you very much, Mr. Shuruf. Okay, now I need to check for raised JVP. Could you please look to this side? Okay, just have a look over the neck of the patient. I couldn't see any raised JVP. Do you have any pain in your tummy?
No.
Okay, just warm your hand before touching the patient's right hypochondrial area in order to check for hepatojugular reflux. Okay, there is no hepatojugular reflux. Now, come again and observe the precordium for a second look. Okay, so in the precordium, we have got this midline sternotomy scar with these two small scars beneath it. Okay, Mr. Shuruf, could you please put your hand like this? So just try to come to look for the lateral aspect in order not to miss any kind of scars, small scars. I cannot see any scars at the lateral aspects. I cannot see any scars at the lateral aspects of the patient's areolas, indicating mini thoracotomy scars. And it is very important as well in cardiovascular system examination not to miss left infraclavicular scar for any devices. Okay, can I see this area, Mr. Shuruf? Okay, I cannot see any kind of scars. Now, the next thing is to come for palpation. Palpation for the cardiovascular system is composed of 4 important steps. Number 1, the apex. Number 2, check for palpable second heart sound. Number 3, check for left parasternal heave. And finally, check for any thrills in the 4 areas: apex, tricuspid, pulmonic, and aortic. Now, I will start by locating the apex, which is normally located in left 5th intercostal space, mid-clavicular line. So let us locate it now. This is the second. Okay. The apex is located mainly in the 5th intercostal space, almost mid-clavicular line. However, it is heaving in nature. Okay, let us see now. Checking for left parasternal heave. I couldn't get any left parasternal heave. Palpable second heart sound in the pulmonic area. Nothing is there. Now check for any thrills. Apex. Nothing is there. Tricuspid. Nothing is there. Pulmonic. Nothing is there. Aortic. Nothing is there. Now, so by palpation, I have identified an undisplaced apex, however, heaving in character. Now, this is the time for auscultation. Pick up your stethoscope. Auscultation in cardiovascular system is an art. You need to start by changing the head of the stethoscope into the bell, and you need to start your auscultation by putting the head of the stethoscope starting by the apex, using your right hand. Your left thumb should be gently palpating the carotid for the timing, for the timing. After that, ask the patient to tilt to the left lateral position in order to pick up the mid-diastolic rumbling murmur of mitral stenosis. And then ask the patient to return back. Change the head of the stethoscope into diaphragm and put it again in the patient's apex. If you detect any systolic murmurs in that area, don't forget to follow it to the axilla in order not to miss that pansystolic murmur of the mitral regurgitation. And then come and check the other areas. The tricuspid in the left lateral border of the sternum, the pulmonic area in the second left intercostal space, and then the first aortic area in the right second intercostal space. And if you detect any systolic murmur in the first aortic area, don't forget to follow it to the carotid. Okay, so I'm going to auscultate right now. There are remaining steps in the auscultation. We will mention it after I auscultate the precordium. Okay, I'm going to press gently. Okay, Mr. Shuruf, can you tilt to the left lateral position like this? Okay, that's it. That's enough. Okay, you can return back. Okay, Mr. Shuruf, can you sit? After asking the patient to sit, you need to auscultate the carotid areas using the bell for any radiation of murmurs, especially if you found a murmur in the aortic area. You need to check for the radiation, and you need to check also for any carotid bruise. In addition to that, don't forget to auscultate also the second aortic area, which is located in the left third intercostal space. While auscultating the second aortic area, don't forget to ask the patient, take a deep breath, get it out, and hold. This is the optimal way to check for the early diastolic murmur of the aortic regurgitation. Okay? So, Mr. Shuruf, I'm going to put this in your neck. Once you are ready, hold your breathing. Okay? Take a deep breath, hold it. Okay? Breathe normally. Take a deep breath, hold it. Okay. Now, Mr. Shuruf, I need you to take a deep breath like this. Get it out, hold it. No. Get it out, yes, hold it. Hold it. No, not like this, okay? Hold it. Hold it. No, don't breathe, not breathe. Don't breathe, okay? Don't breathe, okay? Okay, that's good. Now, come to the back of the patient, and you need to check for any bibasal crackles, and ask the patient, do you have any pain in your back?
No.
Okay, I'm going to press gently for any sacral edema. There is no sacral edema. I'm going to listen now for any bibasal crackles. Take a deep breath, please. Again. Okay. You can lie down now. I have done with the stethoscope. Now come to the patient's lower limbs. Okay, sure. Can I see your legs?
Okay.
Okay. Okay. Do you have any pain in here?
Yes, in the left side.
In here?
Yeah.
No. Do you have any pain in here?
Yes.
Okay. I'm not going to press because he is complaining of pain. However, I can see that the patient has got brownish atrophic lesions. Okay. Nothing is there. Let me check for peripheral pulses. Intact peripheral pulses. Okay. Then the last thing, thank the patient. Thank you very much, Mr. Shuruf. That was so nice from you. Thank you very much.
Okay, welcome back, guys. On examination of that gentleman, by inspection, I have detected a midline sternotomy scar with 2 scars below it. In addition to that, the patient has got a right forearm cannula with no features of inflammation around it. In addition to that, the patient has got foci of ecchymosis affecting his right arm. And finally, the patient has got skin rashes suggestive of diabetic dermopathy affecting his both lower limbs. The pulse was around 84 beats per minute. It was regular, with no special character, with acceptable volume. However, I couldn't assess the synchronicity because of pain in his left hand. The apex of the patient was undisplaced, however, it was heaving in character. By auscultation, I have detected a systolic murmur. This murmur is not related to the respiratory cycle at all, and it does not radiate, with maximum intensity in the aortic area, followed by a clicky second heart sound. Important negatives: I could not appreciate any features of infective endocarditis. I could not appreciate any features suggestive of pulmonary hypertension, and the patient has no features of heart failure. In addition to that, I could not appreciate any pallor or jaundice. To complete my examination, I would like to obtain full sets of observations. I would like to check the INR using the coagulometer, and I would like to do a bedside ECG. In addition to that, I would like to finish my examination by checking the radiofemoral delay and looking for organomegaly in the patient's stomach. So, in conclusion, I believe that this patient has undergone a metallic aortic valve replacement with features of overcoagulation for differential diagnosis. Now, there are a lot of questions that might be raised in such a case. However, before starting mentioning these questions, the thing that is unusual in such a case is the age of the patient. Once you have got such a patient, a young patient with aortic valve replacement, either a metallic valve or a biprosthetic valve in a young patient, you need to start thinking about congenital causes. In addition to that, you need also to start thinking about rheumatic heart diseases and infective endocarditis. And the last thing that you need to think about is the calcification, i.e. degeneration. Because of what? Because of the age of the patient. If the patient's age is 60 years or above, I need to put the calcification on the top of my differential diagnosis. This is the first comment. The second comment. This case is a case of metallic aortic valve replacement. So, how to differentiate between metallic mitral valve and metallic aortic valve, and finally, metallic double valve replacement? If you saw during the examination, it is very important to use your left thumb to put it gently in the patient's carotid in order for the timing of the heart sounds. You need to correlate the clicky sound with the carotid pulse. If the clicky sound is coinciding with the carotid pulse, it means that the first heart sound is clicky metallic, i.e. mitral valve replacement, mechanical mitral valve replacement. If the second heart sound is coinciding with vanishing of the carotid pulse, this means that the second heart sound is the clicky metallic sound, i.e. metallic aortic valve replacement. And in case that you have got two clicky sounds, one of them is coinciding with the carotid pulse, and the other one is coinciding with vanishing of the carotid pulse, it means that both heart sounds are clicky metallic, i.e. double mechanical valve replacement. It is very important in cases of valve replacement to look for anemia, to look for jaundice, and to look for any features suggestive of overcoagulation, in particular in metallic valve replacement. There are a lot of questions that might be raised in such a case. Number one, what are the causes of midline sternotomy scar? Number two, what could be the cause behind these two scars below the mid-sternotomy scar? What is the target INR in cases of metallic aortic valve replacement, in cases of double valve replacement, in cases of aortic valve replacement? What are the differences in between bioprosthetic valve and metallic valves? What are the indications of bioprosthetic valve replacement? What are the complications after valve replacement? What could be the causes of anemia in such patients? What could be the causes of jaundice in such patients? How are you going to manage such patients in terms of investigations and treatment? So, to make it some sort of an interactive session, you can answer any one of these questions in the comments, and I'm going to review all of them. I wish you all the best, guys, and to see you soon in other cases. Thank you very much.